Welcome to Physicians Who Lead, the podcast where we sit down with physician leaders who are shaping the future of healthcare. Each episode, we dive into the real challenges facing our system today and hear directly from the physicians leading the way with innovation, resilience, and vision. If you want to understand how healthcare is changing and meet the leaders driving that change, you're in the right place.
Welcome back to the Physicians Who Lead podcast, where we speak with physicians who are shaping healthcare through leadership, advocacy, education, and service. Today, I'm joined by Dr. Adam Saget, a psychiatrist, physician leader, chief medical officer, and president-elect of the American Society of Adolescent Psychiatry. Whew, that was a lot of things. Dr. Saget brings a really interesting leadership lens because his work sits at the intersection of clinical care, organizational leadership, advocacy, education, and adolescent mental health. He also built a career in areas where leadership matters deeply, supporting young people, families, clinicians, and systems that are often, always under pressure. Thanks for joining me.
Well, thank you for having me.
Yeah, I look forward to mental health as a bit of a area that I really like. So I'd love to start with your path. You've taken on roles as a psychiatrist, educator, advocate, CMO, and now president-elect of the American Society of Adolescent Psychiatry. When you look back, was leadership something you intentionally pursued, or did it evolve naturally from the work you were doing?
I would like to say a little bit of both. I've always considered myself a leader. If I think back to early extracurricular sports and clubs, I found myself as a captain or leader early on. And then when medical school came around, you find yourself in a pool of overachievers trying to continually overachieve. So there are those of us that do that through clinical leadership, through clinical excellence. And for me, I chose leadership.
Nice. What were some of the early experiences that kind of shaped how you lead?
Well, I've been the benefactor of much stewardship and mentorship. Many individuals invested in my development, taught me how to see the world differently, how to envision a world for myself differently. And they imbued upon me an obligation and really a desire and excitement to give back. And in giving back as a leader, I am able to have a broader impact on all the different patients that come through a healthcare system. And if not for those mentors, I would not have seen a road to improving my ability to expand my impact factor as a physician. And leadership gives me that opportunity. And that's one of the reasons I ended up choosing advocacy leadership within psychiatry to have a bigger impact on change.
That was my next question was going to be about the broader impact. So I won't ask that, but it's an interesting thing because I've talked to a lot of physicians and nobody seems to get into leadership for money and career growth necessarily. It often seems to be more mission driven and the understanding that the system allows them to impact more patients than as a clinician, right? And it's it's definitely an interesting perspective, right? It's very much intertwined with people's personalities. So as a chief medical officer, you're not just thinking about clinical decisions one patient at a time like you would as a clinician. You're thinking about quality, access, team support systems, risk, culture, and outcomes. How do you define the role of a CMO in behavioral health today?
Well, I consider a CMO in general to ultimately be the intersection between administrative demand and clinical reality. One of the benefits of being a physician, being a former direct care provider, well, really honestly, a current direct care provider, allows me the infrastructure operational knowledge of the boots on the ground experience, which allow me to then utilize that experience when I'm looking at operations on a larger scale from a corporate lens, from an administrative lens, looking at different KPIs as it relates to a service line, as it relates to a patient experience, a quality initiative. How will this be received by the individuals actually doing the work? Is the ask reasonable? Is there enough time in the day? Trying to use all of that experience to navigate that on behalf of the role. And when you're in the room with the executives and the other administrators, you're representing that point of view of the clinician. And when you're in the room with your clinicians and your medical staff and your providers and prescribers, you're representing the administrative ask and helping them understand where it's coming from, why it's necessary, how we're accommodating for it, and how we will support you in doing it.
How do you balance clinical standards with the operational realities organizations face?
By avoiding mission creep. and drift, right? We have a very strong mission where I work at Preferred Behavioral Health, and we truly put patients first in a trauma-informed approach as it relates to all therapy, medication management, group work, residential work, even with our transportation services from top down. Everything we do is a trauma-informed practice. And what we get to do is we make sure that every initiative we undertake, every program we manage and sustain is aligned with our mission. And we do strategic planning every year, every quarter, and we ensure that we do a mission check. Have we stayed on mission? Have we crept? Have we drifted? Are we still aligned with where we started? And if not, has it evolved into a better place? Or do we need to reconcile and shift our focus back on target?
So, you mean as a CMO, you're obviously the caveat, or the go between, or the leader on both sides, leading up to executives, leading down, we'll call it, for lack of a better term, to the physicians and stuff like that. But what do you think that the clinicians need from their medical leaders now?
They need strong advocacy, Kevin. In a world where productivity becomes more and more of a focus, when revenue cycle management is certainly front of mind for all physician executives or executives in healthcare spaces, and they're really looking at ways of improving every single margin, especially when we're considering VC involvement or private equity involvement as it relates to healthcare enterprise. Productivity becomes the sole lens. And when a provider is asked to be more productive, they feel undervalued as it relates to their current work. And they need to know that what they're doing is enough. There are opportunities to be more efficient, and I'm happy to support efficient practices, effective billing practices, quality practices. But under no circumstance do we support productivity over outcome. The goal still remains to have a high quality outcome, and productivity is important and critical to our operational success. However, we cannot leverage productivity at the expense of outcomes. And the more we can be transparent with our prescribers, our providers, our physicians, our mid-levels, all those that do services under our umbrellas, the more comfortable they will be with these changes, the more accepting they will be of these changes. But they will not be accepting if they are told just to do them for the sake of doing them. So it's advocacy. It's also communication and translation. As I mentioned before, so much of what we do in the executive space is informing policy with our clinical experience and knowledge, our scientific expertise. And so much of what we're doing on the management side of executive leadership is delivering that message to our peers, to our colleagues, to our direct reports, so that they can digest it, understand it, and really turn it into productive work and operationalize our ask in a way that can be successful for everyone.
It's interesting from an executive search perspective. I find a lot of what is a determinant of success is often the missions and culture of the organizations that are looking, right? Because when people have multiple opportunities, they're obviously going to go somewhere where they feel supported the most. And I've had clients where I took the search on initially and realized that the culture, as I learned more about the organization, the culture was prohibiting it. And you had to start looking at how do you develop people internally to start and supporting them to start changing the culture so they can be a more attractive environment for people to come to, right? So
Absolutely.
adolescent psychiatry, it's a very important area because the complex environment, the stakes are high, and the systems around youth and getting access to systems can be difficult to challenge. From your perspective, what are some of the biggest leadership challenges in adolescent mental health today?
One of the biggest challenges in adolescent mental health is a workforce shortage. There's, generally speaking, not enough people like me to serve the number of children per capita in any given state or any given county in the country, for that matter, in the United States. Ultimately, one of the best aspects of a child and adolescent psychiatrist is they are trained to work in systems inherently. So we excel in leadership positions by virtue of our training. But one of the most important aspects of child and adolescent health that affects our ability to be successful beyond workforce is, unfortunately, stigma. We have come a long way in mental health, and the pandemic shined a light on a much needed discussion point as it relates to mental health. However, we're undergoing a cultural transition where we are being put between a push and pull as identity is still being formed. I was just giving a lecture the other day on the reality of transitional periods as it relates to identity. In the United States right now, we have a cultural identity that is in the period of transition. where we have an older version, especially for men, of a persona that is being pushed forward again in response to an incoming new persona that started to present itself over the last 10 to 20 years as it relates to identity. Similarly, with mental health, we're back in that same place where we were at a very positive, forward thinking, scientifically forward place just 5 years ago. And now we're feeling the push and pull of those that weren't comfortable with that reality or not as accepting of that science. And we are still seeing that force of push and pull, that misinformation, that increase in barriers, that lack of access, that decrease in grant funding, that quite literal targeting of psychiatric practices designed to be evidence-based to protect the safety of our children and their mental health and their developing brain. But we have to make sure we fight this stigma, we address it where the children are at in school, and we give them the emotional tools to ask questions, to understand that it's okay not to be okay, and that even as adults, we struggle and we all need help. So we rely on a village to raise children. It's no different when we think of it from a physician's perspective as a child psychiatrist, or from an executive's perspective, looking at an organization's health as it relates to their ability to serve children and adolescent patient populations. What we need to do is ensure we have a robust village of providers, therapists, supports, and educators for our children. And that's no different in a corporate space or a clinical space.
Yeah, it's interesting because my wife is a teacher, and within her setting, the supports for children seem to be eroding as time goes by, right? Like she's had students that, for no fault of their own, are being successful in the school because they need resources that don't exist. They may have existed 20 years ago, but they don't now, right? Because we're constantly evaluating the investments in healthcare and in mental health specifically. So it's interesting from that standpoint. But
And Kevin, we've lost sight of something important there. And I want to be mindful that it has significant value from a corporate perspective as well. At its core, child and adolescent mental health is preventative medicine. And when you conceptualize pediatric medicine as preventative, you can start to really understand, project, and even account financially for the healthcare dollars saved year over year over the duration of their life based on the earlier point of intervention. And it's something that's well documented.
yeah, yeah, and it's interesting. Like I've gone through some therapy and stuff for my children. They have ADHD, and the intervention was quite early, and the thriving that has happened since then, is unbelievable, right? And in a lot of cases, it's a 180 from a behavioral standpoint, and the relationships that I have with them, because we invested the time and energy in getting them the supports that they needed, the overall relationships that we have improved so much, right?
And it's so important. At the end of the day, if we're not investing early, we're missing opportunity. The average patient waits over 7 years between when they've experienced a symptom before seeking out care within mental health. And that's just woefully too long. And if that's a child, think of all those developmental milestones and interactions that would be formative during a 7 year period that
Yeah.
could be more impactful if properly supported. And it's an opportunity there that I think isn't met by most individuals or organizations. And I'm grateful working at an organization that keeps its mission front of mind. Our CEO, Dr. Tara Chalakani, is an amazing psychologist and leader, and she ensures that our mission stays aligned with where we started, which is with our patients, with our children, with our families, and supporting all of their needs.
It's awesome. So on that theory, what does good collaboration look like between psychiatry, schools, primary care, community agencies, and families?
Well, it starts with collaboration. You heard me mention that workforce shortage is one of the biggest pain points in medicine. It doesn't matter if you're a dermatologist, a psychiatrist, an orthopedist, there's a shortage across all specialties. And whether you're a psychiatrist, a psychologist, a therapist, a social worker, there's a shortage across all mental health domains. So
Yeah.
we need to work collaboratively. And what the evidence shows us is that collaborative care models improve access to care and improve outcomes, and they save money. So we look at behavioral health care's homes, CCBHCs, our community behavioral health care models, our FQHCs, our federally funded healthcare centers where individuals can receive Medicaid, Medicare, and other grant funded services where they have individuals that manage behavioral health issues in addition to their physical health issues. And we leverage our expertise. In New Jersey, we've done this with child and adolescent work through a pediatric psychiatric collaborative where child psychiatrists will video into pediatricians' offices to work with the pediatrician to raise their awareness and understanding of how to manage a case properly, knowing that their relationship with their patient is a valuable one that should be supported more thoughtfully with more information so that the pediatricians can be more effective. And then we have behavioral health care managers and coordinators that can be an intermediary between patients, families, providers, and experts so that we can, again, leverage our workforce appropriately to meet all of the needs of patients and families. Creating a diverse workforce is critically important, and maintaining these access points at all intersections for children and families is critical. And if that means being in schools, if that means being with the pediatricians or the primary care doctors, that will allow us all to be much more successful in terms of reaching more patients with higher quality outcomes.
And it's interesting because I'm stuck on the 7 years that it takes to address it, because I'm thinking about, like, my daughter's 13 years old. And if she had to wait till she was 20, that really resonates with me, right? Because it's a completely different person and a completely different situation in life that, at 20, she's in second year or first year of university versus in grade 8, right? So,
Very different.
wow.
And while those statistics are much more specific to adult populations, the extrapolation to children is very fair. The inference is fair. And while it wouldn't necessarily be 7 years, as there are many more people checking in on them, teachers, pediatricians, parents, loved ones, family members, etc., it's still not fast enough. And every day spent without care is potentially months or years extended of disability relating to that care.
Huh. Something that resonates and to think about. So you're also serving as president-elect of the American Society of Adolescent Psychiatry, which is a different kind of leadership role. It's more about advancing the profession, supporting colleagues, and helping shape the future of care. But what does that mean to you personally?
Well, it is one of the earlier culminations of a very long endeavor to try to, again, improve my ability to impact systems, levels of care, standards of care. As I mentioned earlier, and it is a theme in my life, many people have helped me along the way. I had a teacher in medical school that said to me that if you are a great doctor, you will impact every life of every patient you touch or interact with. If you're a great teacher of medical students and residents and fellows, you will impact every patient they touch and they interact with. If you work at an organization or within an administration at a hospital system, you impact everyone that touches their platform, their website, their system, and the orders of magnitude just grow and grow and grow. And what gets me out of bed every day, Kevin, is the idea that I get to impact more people today than I impacted yesterday, that more people can get care today because of something I'm doing or my colleagues are doing than they could yesterday. And the role with ASAP is another version of my journey towards trying to contribute a fraction of what I've already received from organizations like ASAP, the American Academy of Child Adolescent Psychiatry, the American Psychiatric Association, and others that have given me so much that it's a privilege to be given an elected position to be able to give back on that scale. And that's what it means to me, is it's an opportunity to pay back some of the gifts of mentorship and stewardship that I have so gratefully received over the years.
Amazing. What priorities do you hope to focus on in that role? Or are they determined by the organization?
It's definitely a dual process where I get to inform some of my desires and initiatives, and then they have to, of course, align with the board's initiatives as it relates to the association. What we're trying to do with ASAP is to expand its footprint. Transitional age youth is a critical period of development. Our brains undergo their final maturation, that prefrontal cortex, the area right here where our higher level thinking occurs, where we have impulse control, where we weigh and measure decisions, fully matures between 18 to 25. This is also where most individuals are going through secondary education. Most individuals are starting a family, forming their identity as young adults. And if we can have more individuals willing to take on the treatment of this age range, the better our society will be. There aren't enough child psychiatrists, as you've heard. As an adult psychiatrist or a general psychiatrist, you are trained and licensed to treat all ages, but we don't often feel comfortable when we get closer to youth. because we know that there's additional training available if you want to find expertise in that area. But due to the need for this type of service, organizations like ASAP came into being to address that training gap, to better support general psychiatrists in transitional youth spaces. And I hope to use this position to collaborate with similar organizations, those working with student mental health in particular, so that
Mm.
we can champion initiatives together, because we are always greater together than we are by ourselves.
What one thing that kind of leads me to ask about is one thing I think about a lot is, how do we identify and support future leaders? Many physicians are asked to lead, but they're not always trained or supported to lead. And this is something that I've heard over the last year on the podcast and through a lot of my conversations with leaders, is that they take on this leadership role. Sometimes it's not as clearly defined as they thought it would be. Other times, sometimes it's that the adage of lonely at the top, right, where there's not the same level of support and such. And like when I recruit and place clinical leaders, we try and always align it with an executive coach, right? Not somebody that works for me, so it's not self-serving, but somebody whose sole job is to help ease that transition into a new organization, or in the cases of a situation where it's somebody internally being promoted, ease them into that new role and support them and make sure that they, whether they're trying to build a relationship with a chief nursing executive or with a CEO, or, they're a medical director building a relationship with a CMO, that they're supported through that process, right? And I was wondering what you think we need to do better when it comes to preparing physicians for leadership.
Well, there's a lot we can do better. There's so much of medical school teachings that tell us this isn't our lane.
Hmm.
And if we could go back in time and undo some of the failings of our medical school education, that's certainly one I would want to address. One of the things I've learned over the years, and it's not my cliche, but I'm a big fan of them, that if you're not at the table, you're on the menu. And as physicians, we've been on the menu for some time. As medical professionals, we've been on the menu for quite some time. And it doesn't take much for us to be successful in these spaces. We are, as I said before, a pool of overachievers. We are capable of learning new skills. We are capable of becoming expert in other domains. But most of us don't have this experience. Most of us did not have lives before medical school, or lives in other business ventures or industries prior to medical school. It's a portion of us that is certainly lacking. And there could be more diverse education in medical school. There could be more diverse education and fellowships and residencies as it relates to the practice of medicine, the business and operations of medicine. We could create rotations for medical students, residents, and fellows in administrative medicine, which I believe will be the next and most important first step in this endeavor towards creating better physician executives. And then it's identifying those that have the skill sets appropriately. As a psychiatrist, we are predisposed to be leaders by virtue of our training in social psychology. So much of what is taught in leadership academies and what I'm sure your leadership coaches offer has to do with relational work, managing personalities, and understanding nonverbal communications, motivational interviewing, as we might call it from a psychological or psychiatric perspective, and integrating that into your interprofessional practice. So much of our training is spent on allowing patients to improve their relationships, improve the quality of their lives in all domains, that we fail to apply these same skills and tenets to our interprofessional relationships, our personal relationships. There's reasons we're not the best patients ourselves. We don't necessarily have insight into ourselves, but we can seek out education, like I said, to broaden our vernacular, broaden our lexicon. I myself, I'm in the pursuit right now of an executive MBA to add to that skill set. I didn't get enough of it in medical school and residency. And while I was very much intrusive with leaders and asked them to open their books to me, help me along to understand why they're doing what they're doing, what's the why behind this initiative, how is this program or operation going to work, what's 4 steps down the line look like for you. And I was doing that very early on. And it's because of the mentors in my life that spurred me to do that early on. And those experiences taught me enough to know that I'm willing to bet on myself. And in doing so, you find yourself in leadership opportunities. You don't necessarily have to seek them out. Sometimes they are thrust upon you. And if you enjoy it, it's an opportunity for skill building. It's an opportunity to make an experience better for patients and also for your colleagues. And that's one of the reasons that I think I'm driven most to leadership. Besides the patient work, which I find incredibly gratifying, I want to make my peers and the individuals who come to work with me and for me to want to come to work. One of the things I look at every day, Kevin, is if I see an individual waiting in their car before their shift and waiting to come in, I know I'm not doing something right.
Right.
When I see everybody coming in before their shift, when they're staying a little bit later, when the tension is a little looser because the support is a little greater, then I know I'm really doing my job. And one of those things in psychiatry and psychology we are taught are the intangibles of how to get someone over that line from a comfort perspective, from a social perspective. And it allows us to be successful at this level, but we have to be aware we have these skills. We have to be encouraged to cultivate these skills and apply them outside of the clinic and the medical floor. There's such a failing amongst physicians and colleagues to not properly identify a successor, to have succession planning built into your strategic plan, into all of your programs, but also to think about how will your succession plan work out if your successor isn't cultivated at every stage along their path. And having a leadership coach is a tremendous resource, one I wish I was able to have earlier on. And leadership academies are, again, another great opportunity for physicians to continue building out these skills.
Yeah. I think part of what we need to look at is more of a holistic approach to leadership development, because I think there's multiple ways to go about it. And I've seen, I've worked with people that have done an MHA or an MBA or an executive MBA. And, that's very, tactical and theoretical and stuff like that, which is definitely needed because you need to understand the aspects of leadership and the structures and theories and stuff like that as well, right? But I think we also need to, I always use myself as an example, right? I've been recruiting for 25 years. I'm pretty skilled at it from what I would guess. And like I keep signing up for courses, and then you do the course and you realize you learn nothing in the course. So what I've started doing is having conversations with other people that are coaches that know me. So the notion is like, I want to understand how Kevin shows up to work, right?
Hmm.
Kevin approaches his work, and I apologize for the third person, but I sound like a professional athlete. But it's like, how do I show up? Like, how do I implement that knowledge and manage myself and manage my communication? Because I early on in my career, we did a 360 assessment, and the feedback from some of my staff was that I wore my heart on my sleeve, so if I was frustrated, everybody knew I was frustrated, which then
Hmm.
frustrated them, right? So I had to learn to address that different in different ways, and understand and really be mindful of my communication and my behavior and how it affected those around me, right? So thankfully that was 20 years ago, and I've matured a lot since then, apparently. At least that's what I'll tell myself. But what advice would you give a physician who is stepping into their first formal leadership role?
The best piece of advice I was given would be the one I would give here, that not every problem requires your immediate attention. I think one of the biggest failings I had early on was being overly reactive, overly solution driven to ensure that all problems were solved. Every fire was put out. I ensured the highest quality everything except for myself. I was burning out. I was not giving others a chance to grow or learn. So what I've learned is over time, be aware that there are fires that will naturally extinguish themselves. There are fires that have linear solutions. There are fires that have nonlinear solutions, all of which can get you to the same end, and none of which necessarily demand your immediate attention. Take a minute. Don't respond to the email right away. Consider the broader impact of what this person's agency can bring to this problem by supporting it intentionally, by not necessarily giving an answer, but by guiding someone towards an answer. At the end of the day, the old adage of teaching someone to fish versus giving them a fish certainly bears meaning here, but it goes far beyond. We want to give someone an avenue, a design for action, a path towards success, and allow them to get there by showing them the directions that they need, the support that's available, and allowing them to solve their problem. And sometimes you have to be the solution. In a sea of problems, it's always great to be a solution. That said, the best solver of problems is the one that can identify individuals who can solve the problem on their own by using their critical thinking, the skills you give them, the support you provide, and allowing them to lead their solution more so than you have to solve the problem yourself. If one thing could be true for my younger self that I've learned now is that you don't have to be the solution yourself. The best leader has a team, and you need to rely on your team and trust your team.
Excellent. Dr. Saget, this has been a great conversation. I realize being on my podcast is not your full-time job, so I will end it here. But I really appreciate the way you connected clinical care, advocacy, organizational leadership, and mentorship, especially referring to the mentors that you had early on in your career. I think that's something that needs to be highlighted and fostered within our system. But for me, this conversation highlights something that we come back to often on the Physicians Who Lead podcast is physician leadership does not happen by accident. It has to be developed, supported, and connected to a bigger purpose and to a mission-driven solutions. I think this conversation resonated and highlighted that for sure. But thank you again for joining me.
Thank you, Kevin, for having me. I really appreciate the time.
Awesome. Thanks for listening to the Physicians Lead podcast, everyone. If you enjoyed this episode, share it with a colleague, physician leader, or a healthcare executive who's thinking about how we can better support physicians leading our system. Or you can tell me how boring I was and that I should let the doctors and the guests talk more. So have a great day, everyone.